we're ready to do our trial equilibration. As you recall, we've already mounted the maxillary cast based on the dentofacial analyzer. By doing so, we can also evaluate where the position of the maxillary arch sits relative to natural head posture. Even though we're only doing equilibration, it's a wonderful starting point, because if there were any teeth that hung down beyond the occlusal plane, and those teeth also were the teeth that were in premature contact, you can appreciate we would like to shorten those teeth as we begin the equilibration. The objective, therefore, would not only be able to harmonize the functional aspects of the dentition, but to also improve the aesthetic aspects of the dentition. In this particular case, we already realized that the maxillary arch is fairly level in Cochine's face. There was a midline discrepancy, but that's not an issue at this point. The lower arch was then mounted using the bite records that were gained utilizing the deprogrammer. The deprogrammer hopefully validated the initial point of contact on the models or on the mounting that we're able to achieve in the mouth based on what the patient said. As you recall, Cochine pointed to the molars on the right side, actually fairly posterior, and in essence, it was the second molar. If we take the articulating paper now and notice what we have out, we have both the Accufilm, the red, the troll foil, the blue. This would then be removed from its covering pack to be used. We also have, if you like, a variety of different hand instruments to do the equilibration with hand instruments, or actually a handpiece. I prefer to use the handpiece because it's quite fast, so that you can at least gain an understanding of what we're trying to achieve. If we can validate the mounting is correct, then we can quickly determine if the objectives that we need to achieve can be achieved through the use of equilibration. What that means would be, do we have to consider maybe orthodontics, orthognathic surgery, additive components to this procedure, or can we just do a subtractive equilibration and achieve our goals? So the first point, if we take the articulating paper and close the articulator up and down, the initial point of contact should be on the right side, and quite frankly, it's pretty apparent that the left side is actually out of contact. When I open the articulator, you can actually see the initial point of contact is in fact the lower right second molar, just what was pointed to by the patient in the video. Now, as we take a look at the models and the way they fit together, the goal is equal simultaneous contact from second molar to cuspid on each side at also, remember, equal intensity. Now this has to be able to be achievable before the anterior teeth come into contact. If you take a look at this, it seems apparent, even as we start to look at this, right at the very beginning, there's already a small space that exists behind the maxillary central incisors. So our goal is to be able to close this down only enough so that the patient is not hitting the maxillary anterior teeth with the mandibular anterior teeth. Once these teeth are in contact, if we kept on doing the equilibration, we would wind up constricting the envelope. When you look at the models, it's pretty apparent that there's quite an opening on this side. The left side doesn't really touch at all. So the question is, will our goals of equilibration be achievable, or do we have to take too much away from the teeth that currently are beginning to contact before we can get this left side into contact? Let's begin. When you have an initial point of contact, the idea would be not to touch the cusp tip. It would be to deepen the fossa. As you remember, what we are trying to do is focus on building a home. So by deepening the fossa, you can start to be able to empower the brain. And so all I'm trying to do is not worry about blueprinting the entire procedure. I just want to see if I can gain access to what the end point is. So as we start to do it, you can see the dots starting to come on this right side. On the left side, when I close it, it doesn't really touch, right? You could see it just pulls out. And so wherever it's pulling out, obviously there's no contact. This is tight on this side, but pulls here. So when I open this, you will see enough smudge marks. So these are smudges on this side because it doesn't really touch. But in the meantime, we want to deepen fossa and take it off the incline. Now this is on an incline, so this will go away. And then you would look at the bottom. This is on an incline. The fossa is moored in the center. So anything on the sides, that goes away, okay? And so if you start to work through this, you'll see clearly what you're trying to do. This side doesn't really touch, it just smudged. I'm just getting it to hit. Now it's starting to contact here. This almost fossa type incline, you look at the bottom, it's a little bit on that buccal cusp right there. So let's start to work through this. I'm just going to take these marks away. So be careful, by the way, when you see marks with the articulating paper, you need to make sure that you can verify that they are real and not smudges. Remember the potential concerns with false positives and false negatives. So at this point, just so you get an idea of what we're trying to do, in the mouth, anything here and here is taken away because we're really wanting the contact to be on the cusp tip. So I'm going to switch these to blue, so we'll see what we're able to achieve. So we have contact almost to the second bicuspid, but we have one starting to happen on this left side. And notice it was just here. And you would keep doing this until you get as many contacts in the posterior without any in the anterior, or at least until the cuspids couple. If it's on a cusp tip, don't touch it. And sometimes it's a good idea to just go back and forth with different articulating paper to be sure that you're not staying with any false positives or false negatives. And you can see it's still on mostly the right side. Deepen the fossa. Do not touch cusp tips ever. You can, anything on the inner aspects of the lower teeth, on these inclines of the lingual half of the lower posterior teeth, you should take those away also. They don't need to be there. We're trying to move all the contacts to the central fossas and stay as much as possible right on the cusp tips. Sometimes I like to go back and forth between the red and the blue so that if you get some red marks and they're real, they should be able to be superimposed with the blue ones. So now you can see exactly what I mean. So be careful when these areas start to touch. That is not a cusp tip. This is on the outer aspect of these lingual cusp tips. This is why many times when you see these come back from the lab, if these are maxillary crowns and they're really fat and rolled, they present problems because you already know that that contact would be on the inner aspect of the lower tooth. So if you looked at it, that contact would be right there. That's not what you want. If this was a crown that you just placed in the upper arch, and this was a large MOD alloy, this would be a distal lingual cusp that would be at risk to be fractured. So this, just take these away. All of these on the inside. Same thing on the outside. We're only trying to preserve what's on the cusp tip. That's why when the crowns come back and you don't really have cusp tips, they look really kind of fat looking or rolled. They're so much more difficult to work with in the mouth. This is what I want. I want to keep tips just like that. Anything central fossa, take it away. These areas of the lingual, take those away. They shouldn't be there. Right? That would make that easier for you. The sooner you get those out of the way, the easier it'll be to make this work. So we're continuing to make progress. And remember, the goal is to get equal simultaneous contact, cuspids to second molars with equal intensity, and no contact on the incisors. That means no P2 contact and no P3 contact when the patient is chewing. I don't want the incisors to be able to hold shim stock. Cuspids back would hold shim stock. Now that doesn't mean you can't put thicker articulating paper in the mouth and get some marks. That isn't what I'm concerned with. But I don't want those teeth to be in excessive contact or in any fremitus at all. At this point, you can start to see the marks very clearly. Second molar, first molar, starting to move up. This bicuspid, we don't have these two bicuspids in contact, nor do we have the cuspids. So we're getting close. If we go to the bottom, these are on the cusp tips. I'll take the central fossas away. So at this point, it would be these central fossas deepen. Any inclines will come away. So we continue. And remember, hopefully we can get all the way to the cuspids. And the comment in the manual is when the first cuspid comes in contact, think about stopping. Use the red. Again, you can start to see all four of these teeth are now in contact, two of these teeth in contact. These are clearly on the cusp tips. All the upper lingual cusps would be left alone. We would continue to deepen the fossa, making sure it's only on the tip of the cusp. not any of the incline of the cusp. If there's any contact on the incline, when the patient touches and squeezes, it could shift the jaw to one side. As you can see, we have almost both cuspids completely coupling. Let's go ahead and check. I don't see any marks on the cuspids yet. I'm going to switch out to a fresh piece of red paper. Hopefully there's no contact in the front or in the anterior. Fossa. We're very, very close now. So we'd like to continue until these two bicuspids and at least one of the cuspids come into contact. In the mouth, this would be accomplished with the KS0, sometimes also with the KS4. Both of them would be fine diamonds. What we would then do is, as we get just about to the cuspid coupling, in the mouth the deprogrammer will come out, and you'll see that on the DVD. The deprogrammer will come out, and the rest of the way would be done on a brownie point. We're getting very close, as I mentioned earlier. Clear marks through the bicuspids. Still, it looks almost the same on the other side. Remember, what you're trying to do with the trial equilibration is not necessarily mimic exactly how it will go in the mouth, but at least get an idea of what you'll be up against when you try to do this in the mouth. And my point is, this left side is going to take a lot longer to get into contact before we actually get this accomplished. So the right side came into contact fairly quickly, but the left side did not. It's the same thing that should happen in the mouth. Starting to come in actually fairly quickly, fairly almost complete right now. This tooth, this tooth, this tooth, these are all in contact. Now here comes the second bicuspid, still the molars. So we have one more tooth to bring in, and by the time I believe this one comes in, this cuspid on the right side should be in contact. As we continue to near the end of the equilibration, this left side is still being a little bit more stubborn, but at least we're gaining ground that it looks achievable. Now, for the first time, we can see this right cuspid coming into contact. We have contact on all the teeth on this side. We have both molars, a light contact here, a light contact here, and not a contact on this left cuspid. It's very close, as you see. Now we have to decide what we're going to need to do to get it into contact in the mouth. In other words, if it looks like it's too tight in the front or behind the anterior teeth, this may be as far as I'll take this. It almost appears if I do much more, I'll have to start to relieve the back of the maxillary anterior teeth or the facials of the lower anterior teeth. Right here, it tells me at least I could get equal simultaneous contact on both sides, most likely a driveway on both cuspids, but at the very end, this may not be the only part of the driveway. But remember, if this patient has equal simultaneous contact that is very, very easy to get into, meaning that the brain doesn't require effort to find it, it can find where it fits very easily. The envelope will be very small anyway, and the requirements of a driveway will be minimized. Anterior guidance works best when you don't need it. In other words, as the patient closes up and down and chews, very rarely puts any load on guiding inclines. Most of the load is as this patient would be moving into MIP, not on inclines. At this point, I'm very happy with the end point for our trial equilibration, and I would have no problem going ahead to accomplish this in the mouth. We're ready to do our equilibration technique for Katrine. Katrine's history was that she had some previous orthodontics, and following the orthodontics, she developed headaches. After an attempt at deprogramming, and we thought we might be able to resolve the headaches, there was a decision made that she go back into orthodontics. As a matter of fact, when she went back into orthodontics, the headaches disappeared almost immediately. Isn't that correct? After the orthodontics, when the ortho was stopped, the headaches started to return as the teeth started to tighten up. So we went ahead, we made the decisions to fine-tune this equilibration to ensure that we can resolve the headaches. Now, remember, the first thing that we want to do is have the spot, that single spot, tap up and down, and the patient has a single spot right in the center. That spot is the confirmation of the deprogramming. As long as that spot can be validated the way we've talked about before, and that's already been done, Katrine has already gone through the deprogramming phase. So the equilibration technique begins by reducing this spot. And in reducing the spot, remember, it's absolutely critical that the spot stay totally level, because as you reduce this, if it's not horizontal, as the mandible closes, it may deflect to the left, it may deflect to the right, or it may be even distalized. So the goal, and the very important goal, is to keep this absolutely level. Sometimes I like to use references, for instance, the labial bow. If it's level, I can keep this perfectly horizontal to the bow. Now, the tricky part is the spot for Katrine is getting very close to the back of the front teeth. So I'm making it shorter, and eventually a posterior tooth will come into contact as I continue to shorten the vertical height of the platform. Katrine, could you just tap up and down for me? Anything touching in the back? Nope. Let's mark the spot again and see where it is. I see the red spot. It's moving closer to the front, and because it's moving closer to the front, I'm concerned that I'll hit the back of her front teeth as I reduce the platform. So I'm actually going to take the deprogrammer out and reduce the platform in my hand. So I'm going to come a little over to the side. It's good. We'll come back and place the deprogrammer back in the mouth. Now we'll go ahead and try and see where the spot is. Okay. Perfect. Close. Any teeth hitting in the back. Okay. Again, I'll take the deprogrammer out and reduce the spot. Again, remember, care and attention must be to keep the spot absolutely horizontal on that platform. Now close, you should be really close. Can you touch any teeth in the back? If you squeeze, can you touch any teeth in the back? Not yet. So one of the things, it looked to me like the patient can actually get fairly close to her teeth. Kate, let me have the thick articulating paper. Remember, our thick articulating paper is 200 microns. Close down. And see, this is tight. I can not pull this out. Open. That means she's within 200 microns of actually touching the teeth. Same on this side, although this side is a bit looser than the other side. If you remember from our trial equilibration, the initial point of contact was on the right side. It was the second molar on the right side that was in occlusion. We should be able to find the same thing as we continue to close down the deprogrammer. I'm going to take it out again. Don't put your teeth together. Kate, let's put cotton rolls between the teeth. Whenever we take the deprogrammer out, it's critical that the patient does not touch back their teeth. If they try to articulate on their teeth, they'll bring back the memory pattern of their own occlusion, and that's not what we want. Just very gently tap up and down. Do you feel any posterior teeth starting to come? Where is your initial point of contact? On the right side. Let's check to see if we can verify what tooth that is. We'll dry it. And what I'm going to use is the thin articulating paper. We'll use the red one. And see if it actually is touching on the right side. And this red paper, we've put Vaseline on the paper so it's ink, so the ink will work much better when we try to mark the teeth. Tap up and down. Open. Close. Stay closed. Open. And that's exactly where it is. So if you take a look, you'll see there's an initial point of contact. Right on that second molar. Now, as we begin the equilibration, I don't want to touch any cusp tips. I only want to deepen the fossa. So we'll take the KS0 fine. I'll go to the top. And we'll just reduce the tooth in the central fossa. Okay? Once I've reduced the tooth in the central fossa, now nothing touches. Is that correct? Nothing touches. Tap up and down. It doesn't touch. We'll go back and we'll mark the platform in the front. Okay, I'm going to take the platform out. Don't touch your teeth together. We're getting actually very close. This red mark on the platform is moving very close to the lingual of the anterior teeth. So she's getting very, very close. Tap up and down. Do you feel contact now?
Yes.
Where do you feel the contact?
On my right.
On the right side again. Again, just like it was when we were trying to do the equilibration, it seemed to be on the right side for quite a long time before the left side came into contact. Go ahead and tap up and down. Okay. We already have a few contacts on the right side. So if you take a look at the contacts, can you tell which tooth appears to hit the most? No. All right. Right in that region. Whenever the patient starts to point to a tooth, I like to take shim stock, close down, and see if they're right. And this actually does hold. So it's exactly where she said it was holding. Open, close. See, in the back, it doesn't really hold. Close. You see, so we have actually false positives on those posterior teeth. This is the only one that actually touches. And what I'm trying to do is create a mind-body connection for the patient, so the patient can actually feel which tooth it is. So in effect, it is only this bicuspid. Now again, it's on the cusp tip. I'm going to come back and deepen the fossa. So I use the fine diamond, I deepen the fossa, and at this point, it should have no contact on the posterior teeth at all. In other words, I continue to remove contacts until the contact comes back onto the deprogrammer on the front. In that way, I'm stabilizing the jaw, so the jaw is not deflecting from any inclines or any posterior teeth until I get more of them to start to touch. At this point in time, do you have any contact on the back?
No.
No. So now I can come back to the deprogrammer. Sometimes when you take the contact off the tooth and ask the patient to close on the deprogrammer, they'll say, oh, no, I still have contact in the back. And so as the jaw continues to seat and close, you still may pick up posterior contacts. Those must be completely removed until the patient comes back on to the deprogrammer. At this point, the deprogrammer will be relieved again. Making sure that the spot stays as flat as possible to have absolutely no inclines. Now, as we put it back in, do you feel any contact in the back?
Yes.
Where?
Right and left.
You're starting to feel the left side. On the left side, where do you feel the contact? Back there. When you feel the contact now, is one side stronger than the other side?
Perhaps this side is a little bit stronger.
This side's a little bit stronger. Let me check with, we'll mark it, tap up and down, open. You do have quite a few red marks on that side. Let's check with the foil. We're going to check with the mylar. That one holds. Close. That one holds. Can you tell which one is the heaviest contact? That one. Now, let's try this. We're also going to use some troll foil. Open. This is the blue articulating paper. The red one is Accufilm. Tap up and down. Open. We're starting to get our marks. So as I'm adjusting, I go ahead and adjust the marks. And so remember, where I'm adjusting the marks is where she pointed. I'm taking away from those central fossas. Let's try it again. We'll mark it with red. Tap up and down. Now where do you feel the contact?
On both sides.
Starting to feel it on both sides. Let's go across the front. I'd like to see where the deprogrammer is. I'm going to double check, see if it's holding very much here. Close. Stay closed. Still holding here. Open. At this point, the contact off the deprogrammer is very close to the edge, which means she's almost all the way closed down and she's coming close to the back of the front teeth. That's a really dangerous time because I get worried about constricting the envelope. I don't want the patient to be hitting into the front teeth until all the back teeth that I want in occlusion have already been accomplished. At this point, I'm going to take the deprogrammer out, and the patient will now, for the first time, activate on her teeth. And so we won't need this anymore. You're already in centric relation. At this point, all we really need to do is equalize the intensity of the contact, and we shouldn't need anything more than a brownie point. Where do you feel the contact now? On the left side. We'll mark the left side. And I'm going to pick up a brownie point and say, which tooth do you think it is on that side? That one. And all I'm willing to touch are anything's on inclines, central fossas, not cusp tips. And then I'll come back and ask if it made a difference. Tap up and down. Did that make a difference?
Yes.
That means I was in the right place. Now where do you feel it? Further back. So I saw that red one. That was on that incline, right on that molar. Tap up and down. Open. So there's an incline contact on the molar. I'm actually going to smooth that one out. And anytime I'm not sure, one of the things that's a really good idea is to use the red paper followed by even the blue paper and switch the colors back and forth. So let's double check. We'll go red. Let's go the blue. I want to see the blue marks. And if the blue marks are right with the red marks, you can see this is starting to work very nicely. You can see how the central fossas are starting to line up. This one is a little bit on this lingual incline. I'm going to take this one off on the lingual incline. On that second molar, there's a bit of a dangerous one on the inner incline of this particular cusp. Second molars I don't want in any pre-contact. So I'm going to take that away. Anything on an incline that could skid the jaw. And now ask the patient, tap up and down. How does that feel?
Very good. But still.
Very good? Not the right answer.
No. Just tiny bit.
Tiny bit up here.
Yes.
All right, let's try that. Which tooth? This one or this one?
That one.
Okay, and right now I'm starting to get a contact on this cuspid. If you can see the little spot on the cuspid, they're just starting to couple now. So we should be pretty close to the very end of this equilibration. I just want to make sure I have complete equal intensity contact. I'm sorry, which tooth? Did you feel it now? 13. So I'm going to come in right on the central fossa, only with a brownie point. Where do you feel it now?
No, I don't feel it now.
Okay, now check the bite.
Just a little bit more.
Just a little bit more.
This one here.
Okay, we'll go further back. Let's mark that again to be sure. Let's go with the red this time. I don't want to lose the context I've established. So now I can see it. It's a little bit further back. Anything on inclines. Now that should have made a difference. And so we'll go ahead and place this and ask the patient to chew. Just chew from the outside, chew from the right, chew from the left. Okay, stop. We'll take this out. You can see the blue streaks on the posterior teeth. And so I'm going to remark the holding cusps. Let's take the red paper. Tap up and down. Open. And on my side. Okay, open. So what I'm going to do is not touch any red dots, only the blue marks. So I can take all of the blue away, but none of the red away. So this won't change the feel of the bite. It only changes and reduces the risk of chewing interferences. This is that dangerous one that we talked about earlier, these inclines on these second molars that not only could deflect the jaw, but could actually create a concern if they were in slight pre-contact and the patient squeezes on those, they squeeze from there into the front teeth. So I haven't done anything to change the actual occlusion. I'm just reducing the chances of chewing interferences. How does that feel right now?
Very good. Perfect.
Perfect. Okay, that's the right word. You don't feel anything in the way at this point, and you don't feel like your bite can slide or move when you tap up and down. And then I'll take my fingers, tap up and down. I want to make sure I feel no fremitus on any of the teeth in the entire arch. Oh, feels perfect. Okay, that's perfect. I think we'll stop for today.